All right. So bicuspid. So Cecile, let me ask you, how how low risk or what low risk patients are you doing TAVR and what who have bicuspids? Are you doing any low risk bicuspids?
Not for the most part, no. I mean, there are some bicuspids that have ideal anatomy that we really, the minimal calcium, not a heavily calcified raphe, really have equal sinuses that, we do tend to go ahead. But if there's any of these higher risk features in these bicuspid valves, we in low risk we haven't been doing. Now it depends what you say. 75-year-old that's reasonable risk for surgery. That we may treat that patient, but with a careful discussion with the patient. But in general, true low risk younger patients, we are not doing.
I'm interested. What did you do with that accurate patient that didn't expand?
No, that was from the gym presentation. I stole that from someone, as you saw on the bottom. It was not mine. So, but I think that would be scary. I'm not sure what I would do. I mean, I don't know how people would handle it, whether they'd put a sapien inside of it or whether what the right answer would be. But these are things that are important to consider. And I think the advantage, the Lotus is that you can assess real advantage that others in that. The other question I didn't get a chance into is, sizing may be different for different valve types. I didn't talk about supraannular versus intraannular sizing. And it may be different for balloon expandable versus self-expanding. And there's just so much unknown that.
Right. I'm having a little trouble with the audio. Does anybody else?
Yeah. I think there are a few other considerations than just the age, right? I think one of the things in bicuspid, of course, is that their annulus tends to be larger. So in theory, in practice as well, you can put in a reasonable size surgical valve. Secondly, we did discuss a lot about durability. And when we discuss durability for any valve, it's in the best case scenario. Best case scenario is the valve's perfectly cylindrical, there is no leak. So I think in bicuspids, in unsuitable anatomies, this scenario is not going to replicate. So we are going to see durability issues as well in a big way. So I think for bicuspid, I still feel that low risk patients where you can implant a very good size valve, I think one should consider surgery. If there are compelling reasons, then TAVR, I think, provided if you have, seen that you're going to get at least a good result. I mean, the last thing you want is to land up like that case Sushil showed, or one of the cases I remember in Tokyo PCR last year, where a very large evolutar was implanted, and it was like this in one dimension, and the operators kept saying that this will work very, very well. And if you get that result, then you should follow that patient carefully. So they're not relegated once and for all out towards the transcatheter side. And I think these patients do well if you treat them properly even later.
I mean, with that, Vinny or others, I mean, are you, Sushil, you didn't mention anything about high implants. Are you doing anything about high implants at all?
Yeah, no, I think the question, and I think there's one other place where the slide sort of hit a hiccup where it was talking about the sealing zone, right? Especially in a type 0, the sealing zone is at the leaflets, not at the annulus. And so these often will have very tall leaflets. And if the seal is going to be at the leaflet tips, you have to be high. And especially, the skirt on an Evolut, is around, I think, 13 or 12 or 13. So if that leaflet is tall and that seal is at the leaflet tips, and you're down at the typical annulus, you'll get leak through the frame. So I think you have to, each patient, depending on what the anatomy looks like, understand where the seal zone is going to be, because that's going to dictate how high you have to implant. In general, you're going to implant much higher. But especially in a type 0 with those tall asymmetric leaflets, I think you have to be much higher. In a type 1, I think it's less of an issue. And I think those heavily calcified type 1s, like some of the examples we showed, I always do a balloon valvuloplasty first to sort of assess what it's going to look like, and also to help the expansion of a self-expanding valve.
I was just going to ask you about that. I mean, pre-BAV for all Evolutes, or pre-BAV for Evolutes and Sapiens, or do you just do case by case?
I'm pretty much case by case, but essentially as a rule for any either Lotus or Evolute, anything self-expanding, I'll do a BAV first. Agree.
Sushil, what factors do you consider when choosing between a self-expanding and a balloon expandable valve in the bicuspid population?
I don't think I know enough to really know. I mean, I think if there's not a calcified raphe, I generally tend to go with the balloon expandable. I think the really horizontal aortas in a bicuspid are really challenging with a self-expanding that tends to be pushed through a balloon expandable. But if the approach to the aorta is good and you have a heavily calcified raphe, and I'm worried about balloon expandable and root injury, I tend to do a self-expanding in those. And I've been happy with our Lotus experience. It's very limited, but I've been really happy with it thus far. And I think the ability to deploy, assess, and then reposition even higher for hemodynamics, or come out and do a BAV if you don't get good expansion. Those type of features, I think, do provide some advantage.
I do like worrying less about PVL for bicuspids with Lotus. I do like that aspect. It's kind of like a little bit of a gimme there.
Sushil, the other question is, because it's a high implant, is there a signal that there is a less pacemaker risk? Because, one of the problems is, of course, if you use Lotus or other self-expanding devices, that pacemaker is slightly higher or substantially higher.
All right.
I think in that responding, again, it's very limited, but it was small. Oh, sorry, go ahead.
No, go ahead, Sushil, and then we're going to have to move on. So finish your comment.
Sure. So yeah, in the small registry, it showed slightly less, but it was still like over 20%. So I don't know that we have enough. And I think there's still a lot to learn with bicuspids, and whether leaflet modifying technologies are going to make bicuspids behave like tricuspids may be the better solution to get a more durable TAVR result, rather than trying to design valves for bicuspid valves. Try to modify the leaflets so the valves fit the anatomy better.